Hello, and welcome to the Impact of Clinical Outreach Education, an introduction to academic detailing. Whether you're watching this just to get a little bit of background information on academic detailing, or you'll be joining us for a future training, we're really happy you're with us today. I'm Bevan Shagori, and I direct our educational offerings here at NARCAD. I have a background in interactive and expressive education, and I'm really excited to support current and future detailers working in public health and beyond to improve outcomes for frontline clinicians and their patients. Over to you, Anna.
Thanks, Bevan. Hello and welcome. My name is Anna Morgan, and I manage the projects here at NARCAD. I have a background in nursing and public health, and I was a nurse for about 6 years before diving deeper into public health. We're excited to be here and introduce you to academic detailing. Let's dive into our goals for our webinar today. So we will discuss the framework and impact of academic detailing and how it can be used as an interactive quality improvement strategy, as well as how it can help clinicians overcome barriers and challenges that they face every single day. We'll also discuss how to build a sustainable academic detailing program for any clinical topic in each of your communities.
Thanks, Anna. So let's talk a little bit about what AD is, which is what we call it around here, and hopefully you will start calling it that too. We also call it outreach education, clinical outreach education, and you may hear it called public health detailing. No matter what you call it, it's a terrific approach to engaging with clinicians on the front lines to change things for the better. It's always interactive, never a lecture, never a series of memos or emails, and it includes one-to-one visits in the frontline clinician's own offices or via a virtual medium such as Zoom. The focus of these one-to-one meetings, which are typically around 20 minutes in length on average, is to ask open-ended questions of that clinician and really understand his, her, or their experiences as a clinician. Everything from the stresses that they face to their own experiences around a specific clinical topic and providing care related to that topic to their patients. It's not just a conversation, though. It also includes visual detailing aids, which is really just a fancy way to say a graphic brochure, as you see in the picture on the right. The detailer or educator uses this to underscore points in the conversation that will help the clinician really understand where this best evidence is coming from and what that evidence really means for care. As we said, that information is always interactively provided. And we're trying to understand the experiences of the clinician, which includes not just their clinical knowledge, but the way that they've applied it, the challenges that they've seen, and what their attitudes and behavior has been towards a specific clinical topic or patient population. The idea is that this conversation remains interactive throughout the entire visit, keeping that practitioner really engaged with the content and continuing to ask great questions to understand where they're coming from. Once that's understood, and once there's a sense of what that clinician might be able to do differently to improve care, a decision is made to encourage behavior change based on a specific action based request. And we'll show you what that looks like a little bit later today. The visit should end with an agreed upon commitment to change. Sometimes the agreed upon commitment to change is to continue having these conversations at a future visit. Over time, this relationship between educator and clinician is strengthened. The whole focus of this process is to build a relationship. And that's why we at NARCAD really encourage longer term relationships whenever possible versus just having one time only visits. That'll help make your program more sustainable, which we'll also talk about a bit later. So now we want to take a step back and try to say, hey, wait a minute. Why can't clinicians figure out how to do some of this stuff on their own? Why can't they catch up with the evidence and figure out how to apply it? Well, there are myriad reasons why that's incredibly challenging. The first is the fact that we have tons of statistics that really show that it would be actually impossible for a clinician to read up on every new piece of literature that comes out every day. Here we have a semi-outdated fact that still underscores how difficult it was almost 20 years ago. And of course, things have increased exponentially since then. Our stat here is that in 2004, it would take 627 hours a month to review new papers relevant for just primary care. We're not talking specialty care, just primary care providers. The other issue is that not only is there too much evidence, but it's not of equal quality. That's what creates this virtually impossible problem for clinicians.
So it takes 17 years for research to reach practice. And even then, the 17 years only applies to 14% of research that makes its way to a patient. What's even more shocking is that only 18% of practitioners report frequent use of evidence-based practices. Yikes. So how do we change all of this? This is where AD comes in. So here's what we know. We have the best available evidence and what's happening on the front lines. And there's a big gap in between. AD is really looking to close that gap. I'm going to hand it over to Bevan to discuss why we need to bring the best evidence to clinicians.
Thanks so much, Anna. So Anna was talking about that gap. How do we fill it? We can fill it by providing high quality data, evidence-based data to clinicians on the front lines. But that data really needs to be carefully selected. It needs to be relevant to their real world decisions in their specific clinical setting. So if I were a detailer, I would take a different approach in terms of the kind of data I would be presenting to a clinician based on whether that clinician is working in a long-term care facility, a primary care clinic, a hospital setting, including an ER department. So there are plenty of ways that you would have to, as a detailer, look at what you're providing and to whom. Not only do you have to figure out what evidence is most important for a specific clinician, you have to make it practical and usable. It needs to be in a tool or resource format. When this is done right, academic detailing, can offer support during a stressful profession. Everybody knows that clinicians are incredibly busy and don't have time. They're always running behind. And so trying to ask them to do something new may seem stressful, but actually coming in as a detailer and building that relationship can really reignite clinicians' passion for care. It can help them remember why they got into this work in the first place, and certain types of information that's provided can really encourage clinicians to do things in a more streamlined way, more effectively, more efficiently, and thus leverage time in their busy days. Again, it's always about continuous engagement through one-to-one visits that are ongoing over time. So why this interactive approach, and where did it come from? Well, we decided to take a look at two big chunks of how information is presented in the healthcare world. The first is looking at pharmaceutical representatives. People may have many different feelings about this particular industry, but everybody knows that drug industry reps are fantastic communicators. They're persuasive, they know how to get down to the nuggets, they know how to translate the science, and they know how to really get a clinician to come on board and decide to do something, whether it's try a new medical device, prescribe a new medication, use a new tool, and do it in a way that really creates an impact. But we do know that drug industry representatives are looking to make commercial sales for the company that they represent. All right, so let's look at that nugget of being a great communicator, and let's marry it with this pink bubble of our Venn diagram, which is academia and research. Now, academics are a trusted source of clinical information. They do deep dives into research and are really able to get down to the nuggets that are needed in a specific clinical area to share with practitioners. However, along with the problem that Anna illustrated a couple of slides back about that research taking way too long to get into the hands of too few practitioners, we also have the challenge that most academics are not trained in being persuasive communicators or effective communicators, especially not to make a sale or some sort of commitment in a short amount of time. So we're going to steal that great communication from the drug industry. We're going to marry it with trusted data. And that's where academic detailing has arisen as the sweet spot between those two pieces. Now I'd love to talk to you briefly about academic detailing as part of a larger multi-layered intervention. Academic detailing can play a key role when any sort of change is looked for clinicians on the front lines, where education on the best available evidence is critical, and where we really want clinicians to be engaged in a new or different way. But when we step back and look at the bigger picture, academic detailing can really be a key part of larger interventions where there are so many other pieces that work well together with this approach. Some of those pieces include working with community level stakeholders, patient advocates or patient navigators, really looking at a care team from a multi-layered approach, not just the folks who have prescribing authority, and really looking at other patient-facing initiatives, such as how are patients getting the economic support that they need to access a medication or a certain kind of care. So academic detailing works best with its friends that also exists along the spectrum of outreach education, even if the person to whom that outreach education is being provided isn't always a clinician. However, as far as we're concerned, the clinician relationship is where we're really tuning in and looking at academic detailing as a key way to move the needle. I'm going to turn it over to Anna now to talk about what clinicians really care about when they're trying to do their work and trying to do it well. Over to you, Anna.
Thanks, Bevan. So these animations are in no particular order. But when we think about what clinicians value and what I value as a clinician, there is a component of recognition. They're taking on a stressful job and have gone through a lot of schooling and have something to offer. So recognizing expertise can certainly help connect you and a clinician, especially when your relationship is first starting out. As we know, time is so important to clinicians in every single setting. Trust and honesty are also a key component of the detailer to clinician relationship and are both important for clinicians when making connections and caring for patients. Clinicians want and need knowledge to serve their patients and need usable tools and resources to do so. Most clinicians realize caring for patients is a team approach, and in order to deliver good care, they need to collaborate, especially with detailers. We're going to shift gears a little bit and focus on the elements of a successful academic detailing program. So many of you may take part in the development of your AD program. So we'll talk about what building a program actually looks like. Training detailers is one small component. When starting out, though, you want to figure out what is missing. Where are the gaps in care? What are the patients not receiving, or what are they receiving that isn't helpful? This will likely come from local or state data. Then you want to identify the change. What's the change you want clinicians to make so their patients are healthier? For example, you may want clinicians to start screening for a certain type of cancer or take sexual health histories. Then you're ready to start thinking about what your team of detailers is going to look like. This will vary from program to program. Some programs have one person who does it all. They're the epi person, the detailer, the program manager. Some programs have 30 detailers and need advice on how to get started. It really depends on the program, but we are here to help. Once you've trained your team, you're ready to go out into the field and start one-to-one visits with clinicians. You can start to collect data on how these visits went, including the messages that were covered and how satisfied the clinician was with the visit. Once you have your data, you can start thinking about what you need. For example, do we need more detailers? Do we need to connect with other initiatives in the community? And you slowly grow your way to sustainability. As you do that, you want to continually evaluate and assess your impact. So what does a one-to-one visit actually look like? In a moment, we'll walk through each step of a visit. Most visits take about 20 minutes, as Bevan had mentioned earlier, and 2 to 3 key messages are covered. It's important to remember each visit is completely unique. There is no one size fits all here, and detailers need to be flexible in order to be successful. So we'll now break down each step of a visit from introduction to closing your visit. All right, we will jump in. When delivering introductions, there's a tendency for clinicians to think that detailers are sales reps. Because of this, you need to deliver a succinct, clear, and contentful introduction that sets the tone for the entire visit and the entire relationship. The best way to introduce yourself as a detailer is to use terms that clinicians understand, like, my name is Anna, and I'm an outreach educator here to help understand more about what you're experiencing. You don't need to belabor the technical term of academic detailing or AD, but you need to be clear about who you are, the purpose, and the value that you bring. Over to Bevan to jump into needs assessment.
Thanks, Anna. And for any of you excited to dive deeply into any of these steps and learn the communications approach that is paired with these different steps of a visit, join us for a training. And for those of you who are going to join us for a training, we'll take plenty of time to break these down. Here's needs assessment, as Anna said, which is really one of the key pieces of a detailing visit. It's where we talked earlier in this webinar about asking those open-ended questions. What you want to do as a detailer is to really engage your clinician. And that means not talking at them, but getting them to share. You really want to encourage them to share stories, experiences, and things that they wish they had related to a clinical topic, whether it's a certain type of program, a certain type of risk or needs calculator, whether it's a script to help them understand how to speak to their patients about difficult topics. You can't figure out what they need unless you ask them. Once you figure out some of the things they might need, you can then choose a key message or two that asks them to try something different. We'll talk about what those look like. So key messages, which come with corresponding features and benefits of those key messages, are again based on what you identified in the step before in the needs assessment. A key message always uses action-oriented words, and you're going to be delivering an evidence-based behavior change recommendation. It's not a random suggestion you came up with. It's always based on the evidence. And those key messages are thought out before a campaign starts and should be written clearly in your detailing aid. Here's some examples of really strong key messages that use those action-based verbs at the beginning. Screen all patients over age 40 who are at risk for colorectal cancer annually. Conduct a thorough sexual history to determine which of your patients may be at risk of acquiring HIV. Check your state's prescription drug monitoring program to ensure your patient isn't receiving multiple controlled substance prescriptions. So again, we have screen, conduct, check, all verbs that really tell that clinician exactly what to do. Once you deliver key messages such as those, you're almost always going to have to handle some sort of pushback. Don't be afraid of that. If someone is pushing back or asking next level questions about how they might or might not be able to apply a key message, that's great news because it means that he, she, or they are completely engaged and actually contemplating trying this approach. Some people think, hey, if I get an objection, it means that this person doesn't like what I had to say. But we encourage you here at NARCAD to think about objections as evidence that you are really fully engaging that clinician. Your job is not to avoid objections. Your job is to recognize, react to, and manage those objections during the visit. So if I were detailing Anna and asking her to screen patients who are over the age of 40 that may be at high risk of colorectal cancer and to do it annually, and she says she doesn't have a lot of time, I might stop and think, okay, she's thinking this is going to take a lot of time to screen somebody once annually and only to screen those who are at high risk. Let me try to present this information more clearly or to ask her how much time she thinks it will take. So again, it's about continuing to ask questions, continuing to assess the ability that that clinician may have to try this new step, this new change. Anna's going to talk to you about what happens after you've assessed those needs, delivered a key message, and hopefully successfully handled any objections. Over to you, Anna.
Thanks, Bevan. Yes, after you have successfully handled an objection, you're ready to move into your summary. So you want to review what you've discussed during your visit. Again, you want to be clear and succinct here, just like during your introduction. You want the clinician to know that you've been actively listening and the information has been received. You also want to reinforce the information that you shared with each other during the visit. Then you can move into closing your visit. Ask for a commitment from the clinician. What is the change you want the clinician to make? So think back to a few slides ago to that program development. What change do you want that clinician to make? You can continue to build the relationship by holding the clinician accountable to this change and then scheduling a follow-up visit. If the clinician schedules a follow-up, it indicates that they acknowledge the value you bring and the important work that you're doing as an academic detailer.
That's true, Anna. And you all may be wondering, well, how do you hold them accountable? You'll have to come to our trainings to learn a bit more about how to make the commitment you're asking for measurable, specific, and something that is realistic for that clinician. So we hope to see you soon. All right. So that was a very quick overview of the steps of a visit. We're going to talk a little bit now about some of the resources you can access before, during, and after a training and throughout your field work as a detailing program. We encourage you to visit us at narcad.org and check out all the fantastic resources we have waiting for you, including resources that we add weekly from partner programs such as yours who have been out in the field and are a few steps ahead of you, but at one point were trainees just like you or folks who were just brand new to the process and are now successful and teaching us what tools they've created to make their detailing programs stronger. We encourage you to join us, and thanks so much for being here. Take care.